Good afternoon. My name is Keith Lamb, and welcome to our November expert panel discussion put on to you, presented to you by Respiratory Critical Care Inspire. And we are actually in our fourth segment regarding ARDS. And so we are going to just real briefly introduce ourselves, go around the panel here. Introduce myself again. My name is Keith Lamb. I'm a respiratory therapist in Charlottesville, Virginia. Thomas?
I'm a respiratory therapist in Ontario, Canada.
Madison? Madison is
You were muted.
I'm a respiratory therapist in Charlottesville, Virginia.
And Troy?
I'm a respiratory therapist in Columbia, Missouri.
Excellent. So we are going to go ahead and get started. We have another panelist, Eric Kreiner, that'll be here momentarily. Thomas, if you want to pull the slides up, beautiful. So like I said before, this is part 4. We didn't go into this intentionally wanting to put together 4 parts on ARDS, but sometimes that's just the way it works out. So I'm going to do a brief overview and review of the stuff that we've talked about in parts 1 through 3. And then we'll get right into part 4, which is predominantly going to be a discussion by Troy, presentation by Troy on a couple of case reports. So and one more thing, if somebody could put the link to our YouTube channel in the comments, beautiful. And you can go back if you like to and look at parts 1 through 3 to sort of tie everything together. So in parts 1 through 3, we talked about the definition of ARDS. ARDS is a syndrome. You have to sort of meet the different criteria to meet the definition of ARDS. We talked about primary and secondary ARDS. Etiologies of primary would be things like chest trauma, infectious pneumonia, etc. Secondary causes or secondary etiologies of ARDS would be, a different organ system that was either injured or dysfunctional that then sort of triggered that inflammatory cascade. And so the lungs get involved in a secondary injury or infection. We talked about the other criteria for the definition, what kind of signs and test results, imaging that shows diffuse alveolar involvement, PF ratios, et cetera, et cetera. And then we really got into the basic ventilator management. And we talked about how primary focus would be to use protective ventilation, protective tidal volumes to sort of monitor plateau pressures and driving pressure. And we talked about a lot of advanced management interventions. We talked about EIT and esophageal manometry, prone positioning, etc. We talked a little bit about neuromuscular blockade, and then in what patients maybe neuromuscular blockers would be indicated. And then and now we want to sort of talk about how you progress to supportive care or from supportive care to liberation strategies, and then get into our case reports. So that's sort of a real quick overview of what we've talked about so far. And if you have questions, again, as always, these panel discussions are very informal, and you should feel free to put questions into the chat box anytime that you feel like you want to. And if you want to review something that we've already talked about a little bit, that's fine too. But we are dedicated to wrapping ARDS up in this part 4. So
There shall be no part 5.
there shall be no part 5
That's
until
our mantra for today.
maybe in the way distant future, but not anytime soon. So liberation and transitioning to liberation. So, and we'll talk about this with the case reports, but there comes a time in an intubated ARDS patient where you either have to transition to tracheostomy or you have to transition to extubation. And so like most other pathophysiologies and most other reasons for intubation, your primary focus should be, okay, well, what was the reason for the patient to get intubated? And whatever that reason is it sort of been mitigated? Is it gone away completely? Is the patient gotten better? As an example, if somebody gets intubated for ARDS that's primary from lung injury or infection, then is that infection gone away? Or is it at least on a trajectory where the patient's getting better? And of course, as the bedside clinician, we have to think about the risk and the benefit of remaining intubated and on a ventilator versus the benefits of being extubated. We all know that as soon as you intubate somebody, you really should be trying to think about what your game plan is and how you're going to most expeditiously get somebody extubated, right? And so that's how you sort of transition to extubation and liberation from the ventilator. Maybe liberation from the ventilator really involves just being trached, right? And so you sort of, again, what's the risk and the benefits of being tracheostomized or being extubated? Because we all know that the indications for intubation and mechanical ventilation are not always the same things, right? And so would the patient be better off being off the ventilator but being trached? So any of the other panelists have anything to add about transitioning to liberation?
Well, it can be tricky for sure. Trying to find that right balance of taking the neuromuscular blocker off, the sedation, how much is too much effort. It's a fine balance.
Right. Thanks for joining, Eric Kreiner. Can you tell us where you're from?
Sure. I'm from Washington, D.C. I'm a respiratory therapist down there. Sorry.
And Andy joined us as well.
Oh, that's right, Andy. Where are you from? I forget. No, that's not just kidding.
Yeah, sorry, team. I had to do a full reboot, but here now and ready to roll. Respiratory therapist from Chicago.
Welcome, gentlemen. Welcome. So I did a brief recap on what we had talked about, parts 1, 2, and 3, and now we were sort of diving in, doing a brief dive into liberation strategies. When do we know that an ARDS patient is ready to be liberated from the ventilator? And does that incorporate being tracheostomized or just extubated and placed on some other support?
I think, yeah, there you go. Safety, comfort, liberation. I think even before you get to liberation from the ventilator, you got to somehow figure your way out of safety into comfort, right? Like when that occurs, I'm late to the game, but I'm not sure if you'd kind of talked about that. That is also kind of fraught with problems, right? You find yourself, sometimes going backwards, right? You think you're moving forwards through that process, and you don't find kind of the right recipe for comfort, or it's more difficult, or you kind of, maybe jump the gun a little bit. You're asking them to do, I don't know, you find an imbalance in assistance between over and under, or you've asked them to do too much inside of a not ready, non-compliant lung that they're exerting too much effort. So I think that transition to some sort of spontaneous ventilation that's assisted is also problematic, even before you go into liberation. And I don't know that there's any right answer for that one, right? Like when do you go? I think you gather the data and make your best decision. In terms of being able to provide that transition from safety to comfort.
I think it gets even more complicated too, Eric, with I think knowing when to lighten up. I mean, assuming you were sick enough that you needed sedation or even paralytic, when do you lighten that up in terms of you get so much time before you start to have side effects related to sedation and paralytic, and usually that's within about a 72-hour window. What if they're not better by then? Then you got to make those decisions of well, I know I should be turning the paralytic off and or turning the sedation down, but then they're going to get asynchronous, which the data is pretty clear on the fact that asynchrony can be as harmful as just not lung protective ventilation. So I think that makes the decision even more complicated of, balancing that, do I leave them paralyzed a little longer because I know how sick they still are, knowing that on the backside I'm going to have to pay for that somehow. I think that makes it even a more difficult decision.
I think, as maybe Tom would agree with me here, I don't know that I'm as deathly afraid of dysynchronous ventilation as I was previously, right?
Yeah, no, I was going to make a comment about that too. I would say a lot. There's quite a few studies now linking the presence of asynchronies with actually good outcomes, because what it's telling you is your patient's ready to get off the ventilator. Yeah. So we need to be careful about recognizing asynchrony and then having that knee-jerk reaction of this is bad. We need to go back into the sedation / paralysis state. So we need to be cautious of that. There are certain asynchronies that we can easily say this is probably not good if the patient has constant breath stacking and the tidal volumes are double what they should be. But things like ineffective efforts can be related to prolonged mechanical ventilation. But that asynchrony in itself is usually associated with over support. So in that case, you would again wean the patient but when you wean them and they start triggering all the breaths, you might not be happy with their rest rate and it may require some interventions, but we do need to be a little bit careful with that statement. So I agree with you, Andy, and this is sometimes the confusion. There are some asynchronies that we are and should be concerned with, those mostly being breath stacking, particularly in the person in the recovery phase of ARDS, because obviously you can facilitate further lung injury. But just the presence of asynchrony is not always a bad thing. It usually means that you need to be more aggressive with weaning your patient and or just going straight to an SPT and see how they do without any support at all, where you're not fighting the ventilator in terms of what the ventilator wants to give you versus what you want. So yeah.
Yeah, well said, gentlemen.
Yeah, so I think it's nuanced, right? And I think we're learning more that maybe those aren't necessarily the bad markers we thought they were.
Yeah,
first to go forward.
Someone just asked, can I repeat the last point? I'll try to figure out what last point you wanted me to repeat, because I kind of just had a big run-on sentence for about 2 minutes. Essentially, what we're saying is that just because you see the patient is asynchronous with the ventilator, some studies have shown that the presence of asynchrony simply tells you your patient is ready to wean or come off the ventilator. So seeing them start to interact in a way where the ventilator is trying to control them and they have their own drive, it's important to do things like a spontaneous breathing trial to see how do they do without the ventilator trying to over support them, for example. Whereas some asynchronies, like someone who is still in the recovery phase of ARDS, who then starts breath stacking nonstop, it makes sense to be concerned with that. or a patient with really, really high drive who you're trying to wean and just you cannot control their drive and you can't make them comfortable, there's an association with worse outcomes. But just the presence of asynchrony, we just have to be careful that we don't see, oh, my patient seems to be non-synchronous with the ventilator. We shouldn't automatically think that we need to sedate them. In fact, it may just be telling you that you need to be more aggressive at weaning them from the ventilator or liberating them from the ventilator. I hope that cleared it up.
Yeah, I think it's fair to say that the paradigm shift of sorts over the last bunch of years now has been instead of knee-jerk trying to make the patient fit the ventilator, to focus more on making the ventilator fit the patient. And that sometimes if they're dysynchronous or asynchronous with the ventilator, if the patient is, then it's purely because they've got a good spontaneous drive and they may be ready to liberate. And in my own practice, when I have an ARDS patient, I don't necessarily treat them differently in terms of the way I liberate them, or what my evaluation process is for liberation. But one more quick question about liberation, then we're going to move into the case reports. When you have a patient that you've decided that you're going to extubate, regardless of whether or not their experience or the pathophysiology has been ARDS or not, how do you decide if you're going to extubate them to some sort of non-invasive support, that be high flow nasal cannula or non-invasive ventilation?
I think the patient Tom just described. I mean, like, you got them where, okay, like, I'm in this window where I either resedate them if I'm, thinking that the asynchrony is something, or if I think I can relate that back to, okay, well, this patient has adequate drive to breathe on their own, but maybe I'm still on 60% FiO2, and that is my barrier to extubate. Well, then I'm going to, potentially extubate them anyway and put them on a high flow, high humidity nasal cannula in that situation. Or maybe their CO2 is still, 52, and I'm kind of, they're waxing and waning about whether they want to extubate somebody with the CO2 that high, but everything else points to extubation. Then you can look at that and say, I think this is close enough. I think we can manage it on non-invasive ventilation in favor of getting the taken out. I don't know how everybody else's practice is. That's pretty much my practice is.
Well, I think we need,
and I think you can get them off if you put them on something else, then you try to do that.
Yeah, I think we need to consider the current guidelines. So they've put a lot of work into looking at the evidence as to like whether or not we should be, how we should manage people post extubation. And first off, I'll state that the only patient in which extubation to NIV, for example, would be considered when they have not passed a spontaneous breathing trial is the case of a patient with COPD. There is evidence. It's one part of the guidelines is that it's one of those conditional recommendations that you could extubate a patient with COPD early, provided that they're just not passing an SBT, but they're on settings you could easily manage with NIV. This is a patient. Other than that, every other recommendation for providing, whether it's high flow or NIV post extubation, does require your patient to pass an SBT. So for SBT passing, typically oxygenation is one of those criteria. So if your patient has zero help from the ventilator and it's only the oxygen that is the concern, you could argue that maybe getting that patient off of the ventilator, but keeping in mind that the patient immediately is meeting many people's criteria for intubation based on the oxygenation needs. It really comes down to what is their drive, what is their respirate, are they struggling, are they this happy hypoxemic patient that we saw sometimes with COVID? But chances are you do still want to make sure these patients pass a spontaneous breathing trial. And when it comes to extubating these patients to NIV or high flow, there was a really good systematic review and meta-analysis published recently that looked at the number needed to treat in terms of extubating people, and it had the severity or the risk of failing extubation of like 5-10%, and I think up to 40% risk. And of course, the more riskier this patient is, meaning they have many criteria that are associated with failing, the higher the risk, the more beneficial it is to provide either NIV or high flow. In the highest risk patients, NIV was the the one that provided a number needed to treat, and high flow kind of fell short of the really high risk patients. But when they did the analysis, they look at a combined, and I'll actually bring this slide up in a moment. Like I'll bring this paper up and we can just quickly show it, and I'll give a link to it. But essentially, when you combine extubating high-risk patients to NIV, and then while they're getting breaks from NIV, giving them high flow, the number needed to treat to reduce reintubation is significantly higher. So the evidence is clear. Any high-risk patient, so someone recovering from ARDS could be considered a high-risk extubation patient. These patients, the evidence suggests that we should be extubating these people to some level of support. And the higher the risk, the more likely you should choose NIV. And this is NIV directly post-extubation, not waiting until they fail to provide it. I'll call up this paper and put a link in the chat.
Madison, do you have something to say?
So that's great information. I think that sometimes, we focus so much on what do we do next, but I think it's important that we make sure to evaluate the patient after we apply a therapy and determine if it's the right thing, and knowing when to intervene and escalate or de-escalate therapy, which isn't always straightforward, but I think that it's important that we continually evaluate what we're doing with the patients and intervene as indicated.
I will apologize. The link I'm going to share, the article is not open access. However, if you are in a hospital, you probably could get access through the library. Some hospitals will allow, they have like a library link somewhere on their desktop. If that's still a thing in most hospitals, it was in a few hospitals I've worked at. But I'll also quickly just share that table. If anybody is on a computer and they want to take a screenshot, then they can do that as well. So let me just find the tab here. So this is that table that I was discussing, looking at if your risk of reintubation is low, so 5%, then you would need to treat 60 patients with NIV in order to, prevent one reintubation versus high flow.
We don't see it yet. We don't see it yet.
You don't see it? Oh, that's because it's not, hold on. I need to do this. Whoops, add that and remove that. Add a stage. There we go. we can only share one thing at a time, and we were still sharing the other one. So with this graph here, this is just showing for low risk of reintubation, so 5%, you have a number needed to treat if you were to treat them with NIV of 60, which is pretty high. So after treating if you extubated 6 low risk patients to NIV, you would prevent one reintubation, whereas with high flow, it's slightly lower. And then when you get to 10% risk, you can see that number needed to treat drops significantly, but even high flow is still very competitive. Once you get to 20% of reintubation risk, you've got a number needed to treat of 17 and 16, so they're very similar. But 40%, this would be the significantly high risk. You got a number needed to treat of 11, and of course it's NA for the high flow because the estimate here crosses 1, so it's not a significant value. But when you look over here, this is high flow plus NIV. So if you were to combine the therapies, look at how the number needed to treat changes significantly. And then for the high risk, we get down to if you treated 5 people with a combination of NIV and high flow post extubation, you're going to prevent a reintubation every 5 patients, essentially, is what this is saying. And just so people can see the title of this article, let me scroll way to the top. It is in intensive care medicine. I did put the link in the chat, but this is the article here. Very good article.
Thank you, Thomas. I think that we should jump into the case report so we have time to go through them. And obviously, as Troy is going through this first case report, feel free to ask questions of the panelist.
Yes, please do. And anybody on the panel, please pipe in as well. I'm going to present this case probably. If I don't get through any of the other cases, I think this one is probably the most important because this demonstrates an ARDS patient that we treated over about a 10-hour period. It goes from about 2 in the morning till about noon the next day. And all the process that was involved in it didn't involve any special tools or catheters. Anybody can do this at any hospital, any place with any ventilator. We've mentioned before that, only about 10% of patients with ARDS succumb to hypoxemia. Most die from multi-system organ failure. So we try to be proactive and do the best that we can with the ventilator to prevent those inflammatory mediators from going from the lung to other organs and knocking out different organs. I've been a respiratory therapist since the early 80s. And as I look back and see the things we did in the early 80s compared to what we do now, we were doing a lot of things wrong. And you're going to look back 10, 15 years from now and look back to this time and see that we're doing a lot of things wrong. But we want to do the best that we can with the evidence that we have. And that's how medicine works. And so this particular patient, I'll just go through day one. He was a 69-year-old admitted with dyspnea, had a high BMI, history of asthma, diabetes, hypertension. I had a viral infection, RSV, had bilateral infiltrate. So this is obviously had converted into something else. Had a lactic, white count was low. Was hypotense, was placed on a norepi drip. Day two, got progressively more hypoxemia. SpO2 dropped into the 70s. Was placed on a high flow nasal cannula at 100% in 50 liters. And if you look at 2:15 in the morning at the ABG on the far left, patient was 727, 36, and 81. Not long after that, because of increased effort and progressive hypoxemia, the patient was transitioned to non-invasive. And you can see the acid base not much better. PO2 actually dropped. And like Madison was saying earlier, when you do an intervention, you need to decide, is this intervention helpful? Is it not helpful? Always come back and reevaluate the decisions that you're making. This patient was intubated for hypoxemic respiratory failure. And a neuromuscular blocking agent was started because the patient had persistent asynchrony and they were quite hypoxemic. It's always usually our trigger here for neuromuscular blocking agent is persistent ventilator asynchrony with refractory hypoxemia. There's been several studies looking at paralytics versus light sedation with ARDS. We can get into that if you want, but a little bit. But this patient was started on a paralytic. I think you can go ahead and go to the next slide. There's the X-ray. I think so. Here's the settings: volume control, volume assist control, tidal volume of 350, which was 6 mils per kilogram predicted body weight. Rate was 22. We started with a PEEP of 14, 100%. The plateau was 30. Driving pressure was 16. 30 minus 14 is your driving pressure. So plateau pressure kind of edgy right there at 30. Driving pressure high. If you look to the right, you see the acid base similar, and the oxygenation still pretty crappy. First thing you might notice with this particular patient and with the next is that we often use volume assist control in early ARDS. A lot of places think that's Neanderthal. You should never use it. I'll give you a couple of reasons why you might think about using it. Number one, when you use a paralytic, patient ventilator asynchronies become less of an issue. I'm not saying there's no asynchrony issues that can occur with a paralytic, but they're much less likely. Also, we run pH levels on the lower side and CO2 on the higher side with these patients. So the consistency you get with a stable minute ventilation, even if the patient's being turned or cleaned up, which oftentimes results in lower tidal volumes and pressure modes, which can quickly worsen your acid base. Also, in early ARDS, we almost certainly, if there's no reason not to, we'll place the patient in the prone position. And in conjunction with this, we often use heavy sedation or a paralytic. So that was another reason. And this patient was eventually proned here, you'll see in a few minutes. And lastly, another thing to think about, the gold standard to assess lung mechanics, such as compliance and resistance, is using volume assist control with a square flow pattern. I do understand that people are concerned with higher PIPs a lot of time, peak inspiratory pressures and volume modes. But if you think about it, if you transition to another mode and you're given the same tidal volume despite what mode you're using, your plateau pressure is going to remain unchanged. It's not going to change. You make yourself feel better that you have a lower peak using pressure control, but if you have the same tidal volume, your plateau pressure is going to remain unchanged.
Troy, I just want to take a second to just highlight what you just said.
Okay.
For those that are watching, if you have the same tidal volume in the same patient, regardless of mode, and you did an inspiratory pause, that tells you how much pressure is required to hold that volume in the lung. And you are right, regardless of the mode, you would have the same plateau pressure, because this is the pressure that is there to generate the lung holding that pressure. As you mentioned, peak pressure is resistive pressure, and it's a product of flow. So if you're using a constant flow mode like volume control and you turn the flow higher or lower, your peak pressures will be higher or lower. It's just reflecting the fact that there's more resistive pressure, but that pressure is not what's injuring the lung. And we have to make that clear, because some people get super weirded out when they see volume assist control and they're like, wow, my peak pressures are higher. Those peak pressures are a product of the flow pattern and the flow setting, and they don't reach the lung. What you just mentioned, that plateau pressure, is the most important thing to measure the potential for injury in a patient on a ventilator. So I just wanted to highlight that, because I think it's a very important point that a lot of people sort of forget about, that resistive pressure. Like, you could have an asthma patient with resistive pressure, like peak pressures of 50, 60. And honestly, I wouldn't care if that was the resistive pressure. If I did a plateau and it was 24, 25, I'd be like, we're safe, we're good. Resistive pressure is just that. It's resistive pressure, and it's a product of flow.
Right.
I'll add,
And resistance, I should say. But the point is, the resistive pressure is the pressure of the it's like that back pressure from the ventilator trying to get through. But what gets through and can injure the lung is what we measure with the plateau pressure. Sorry, go ahead, Eric.
and I'll just tack on short. We are a volume house out of the gate like this as well. Absolutely. And I think if your therapeutic intention is to limit volume, then you should limit volume. If you ventilate in a pressure limited mode, you don't have control of the volume, right? And I think more importantly in this case, you only ever set airway pressure in a pressure limited mode. You're setting airway pressure only. You never control the alveolar pressure, right? And so as patients fluctuate in sedation levels or whatever have you, the adage of your plateau pressure is always at or below a set airway pressure is not, it's just not true, right? And so you never actually ever are able to control the alveolar pressure directly, right? And that's what you're concerned about. And so I think if you're going to tell me I'm concerned about limiting volume and concerned about limiting alveolar pressure, and you elect to use a pressure limited mode, you're not doing either one of those. You're not meeting any one of those therapeutic intentions within your purview. Now, can you manipulate the situation in which you are safe in that environment? You can, absolutely. But I don't know. I just stand on that. You never, ever get to control alveolar pressure, whether it's during end inspiratory alveolar pressure or end expiratory alveolar pressure, despite what knob you get to turn.
So that's my personal preference is volume modes. But that being said, we utilize ventilator guidelines here, and we can toggle between modes, adjust background settings. It's not unusual that I may come on shift and find two, of the ARDS patients in a pressure assist control. If all seems well, I may leave them right where they're at. But I do think there's an advantage to using volume assist control, especially early on with a paralytic. So,
Troy, did you mention a hypoxemia protocol study that I can find for them? I didn't catch that.
No, I didn't. I just referred to refractory hypoxemia. Everybody knows what refractory hypoxemia. You don't need a definition. It's when you walk in and there's 20 people looking at the ventilator and looking at the monitor. There's that's refractory hypoxemia. It's easy to identify.
The patient's on 100% and everyone's staring at the sats on the screen that they don't like. Right. Yeah.
That's exactly right. Okay. So we went through this slide, I think. Why don't we go ahead and go to the next slide? All right. So we decided to increase the PEEP to 20. Remember, we had a BMI of over 50, if I remember right. So and we also adjusted the respiratory rate a little bit. Here's the background settings. Vasopressor, interestingly enough, the vasopressor requirement actually decreased with our increase in PEEP. So any comments about that slide, feel free to comment. If not, we can go ahead and go to the next slide. Patient, here's an expiratory hold. There was no auto PEEP. You want to be cognizant of that when you're using higher rates. You don't want to create a lot of air trapping. So just a slide here that we did check. None. We can go to the next slide. Okay. Here is with a PEEP of 20. Our plateau did go up a little bit. So here's the ABG 715, still acidemic, 51. We do have a PO2 of 94, a little bit higher. I believe it was 60 something on the last one, 69. Our prior plateau with a PEEP of 14 was 30. Now it's 33, so slightly higher. Driving pressure with a PEEP of 14 was at 16. But now, if you look, even though the plateau is higher, the driving pressure is actually lower. 33 for a plateau minus 20 is actually a lower than 15 driving pressure. Okay.
Troy, could I ask, is there a reason you guys don't implement a pause, an inspiratory pause in this mode to have plateau in real time?
We often do, Tom.
Okay.
I don't know why we didn't.
It wasn't set in this one? Okay, gotcha.
In the next case, you'll see that we have it on.
Okay.
I think it's
this is the beauty of this mode, by the way, for those who don't often use it, is that you can set faster inspiratory flows, and you can use an inspiratory pause to keep an eye time that you're happy with. And if you set a 0.2 or 0.3 seconds, like 0.2 or 0.3 second pause, this ventilator will in real time show you the plateau pressure. And the upgraded, like the Servo U, for example, will also read out driving pressure now. It'll subtract your PEEP setting. And if you know you don't have auto PEEP, then it's a very useful tool. Again, just a real-time monitor. Yeah, sorry.
No, I agree 100%. Thanks for pointing that out. I don't think it's the next case, so I don't know if we'll get to it, but the very next third case, I think we do have the pause on. Yeah, go ahead. Yeah.
How would you explain that you increase your PEEP by 6, but your plateau pressure only went up by 3?
It's magical. No.
That's magic.
So it probably indicates that you're recruiting some lung, right? Now, what are you going to worry about? Are you going to worry about the higher plateau pressure with a patient with a BMI of 30, 50? Or are you going to be happy that your driving pressure is less than 15? Does anybody want to comment on that?
I mean, the evidence suggests that driving pressure is more reflective of potential for harm than plateau pressure itself. So I think, I think you highlighted that nicely. Yeah.
Yeah, and I just add that I would expect somebody with a BMI of 50 to have a higher plateau pressure because of that extrinsic influence on airway pressures that the BMI causes.
So you got to remember, when we do plateau pressures, we use it as a surrogate for alveolar pressure, but it's not alveolar pressure, right? The ventilator can't distinguish between chest wall compliance and alveolar compliance. People that are critically ill often have a higher chest wall, lower chest wall compliance. So.
Well, I think we should be clear. It is the alveolar pressure. It's not the alveolar distending pressure, which is transpulmonary pressure. So so we look at it and we're like, oh, it's good and it's safe, but it might even be safer than we anticipate. Or even in an obese patient, you might have a driving pressure that's slightly higher, and maybe that's okay. Forget obese, even if they have intra-abdominal compartment syndrome.
Correct.
Like there's conditions where they might not be feeling it all. But yeah, it is the pressure reaching the alveoli. But just to I think clarify your point, it's not the distending pressure of the lung. It's not the transpulmonary pressure.
Correct. Okay, I think we can go to the next slide from there. So we did prone this patient. No change in the ventilator settings. Okay. Plateau, interestingly enough, went down just slightly. So now you have a driving pressure of 12, but you still have a little bit higher than 30 plateau pressure. 32 minus 20, driving pressure is 12 now. Sometimes the opposite happens when you prone somebody. Your plateau will go up. Sometimes your drive pressure will go up, down. But in this case, it lowered. And you can see at 10:20, remember this all started at 2 in the morning. The patient's now proned by 10:20 in the morning. And look at the PO2 now after proning, 258. Okay, we still have an acid base issue. But by 12:15 in the afternoon, we've weaned the FiO2 down to 60. Now the PF ratio is I'm not good in my head. I'm going to say 170s, but still much higher than it was. And the end result for this patient, he was prone on and off for 3 days. On day 3, we took the paralytic off, transitioned to a pressure mode for comfort. The patient passed a CPAP trial of 10 on day 11, was extubated for a short period to non-invasive.
What PEEP were they extubated from, Troy?
The patient was on 14 a PEEP. We did the CPAP trial of 10, and then they were extubated. We have extubated from a PEEP of 20. That's not unusual for somebody with a high BMI. But we usually do.
Now, when you say extubate, you mean like directly to NIV for some
usually for
support.
some at least a period of time.
I think I think that's a key point.
Yes.
Because they could look completely comfortable on a CPAP of 16 or 20 or whatever on the ventilator, and obviously if you remove the ventilator and no CPAP, they're not going to look as comfortable. The easiest way to figure that out is just if you turn their CPAP down to nothing, that's what they're going to work. That's how they're going to work when you take them off the ventilator. So it's important to provide that support. It's good.
Any other comments? That's the end of this particular case. Does anybody want to ask a question or have another comment? This is just something that can be done anywhere. Is there something? I mean, any ventilator is capable. You can prone a patient wherever you're at. Any ventilator is capable of getting your lung mechanics and adjusting things.
Yeah. And I will point out, sorry, go ahead, Keith.
I was just going to say there's a lot to unpack there, right? There's a patient, so it's a little more complicated when a patient's morbidly obese with a BMI of 50 and has significant hypoxemic respiratory failure than it is if a patient simply is morbidly obese or simply has hypoxemic respiratory failure, particularly when you get to the point where you're trying to transition to liberation and you extubate them. You decide what kind of, because then you're, so when you're on a PEEP of 10 and you're doing okay, kind of like Tom pointed out, you're not really sure if you're doing okay because you're still on that 10 a PEEP, or are you doing okay regardless, right? Because of the mitigation of the airway pressures and the work of breathing that would be caused by the morbid obesity. And the other thing I wanted to sort of point out were two things. One is, and it's more of a question. I know how you're going to answer this question, but I think for the group, it's important for people that are watching this discussion. The marker of potential improvement in outcomes when you prone somebody, is it because you got that PO2 in the 250 range, or is it because your airway, because your transpulmonary pressure is improved or redistributed?
Yeah, that's a really good question, because we know from past inspection and evidence that it's not, you can get a better PO2 using, say, nitric oxide, but it doesn't translate into improved mortality. So I'm going to be in the camp that it's likely something else. Does anybody else want to comment on that?
Yeah, I'm in that camp too, which is the reason why I asked the question, right? Because I think that the ARDS trial, the control group had higher PO2s. I think that there are several fairly large studies now that have described the lack of effect or lack of an improvement in outcomes solely based on PO2 targets, et cetera. And I think that most people would agree that at least in some part, placing somebody in the prone positioning, just, their PO2 improves, but it's likely a change in redistribution and transpulmonary pressure that elicits further injury that's mitigated by placing somebody in a prone position too. Anybody else?
And we have to be just to get back to when Troy said sometimes the plateau may go up. This doesn't imply that the lungs are in a worse state, and we need to be clear of that, because it could just be simply that the chest wall compliance has changed, because you go from ventilating a rib cage, which is actually quite compliant, to now lying on the rib cage and you're trying to ventilate a spine, which there's going to be less movement of the chest wall, but you hope for more diaphragmatic movement in terms of the dorsal lung regions, which are now the they're now the non-dependent, but you essentially, you hope to have that expansion, but this could take time and it's not always instant. And sometimes you prone a patient and the driving pressure is the same. It might be slightly higher, plateau is the same. And you're like, why aren't my lung mechanics changing? Again, it's always a trade-off, right? You're now ventilating a different part of the lungs, and that's where you're having this, this potential for less injury, is that you're now saying, okay, maybe I have the same pressures, but I'm ventilating a larger portion of lung, right? So the dorsal lung regions are larger than the ventral lung regions. So we have to consider the complexity of the lung morphology. And so, yeah, you may not always see this huge reduction in driving pressure to assume that it's working. So if oxygenation is not working and driving pressure is not working, just know that we're still probably ventilating a more beneficial position for the patient. And this is where things like EIT can come in handy. Like, you can see the benefits of distribution of ventilation when you prone a patient, despite your ventilator settings and numbers not really reflecting that. Mm-hmm. And just to point out, Pablo's mentioning a paper. It's basically the lung rescue team that they had at MGH. We're just going to highlight that we're trying to discuss ways of managing patients without fancy tools, and that lung team basically dropped balloons and used EIT on like all these patients to optimize them. Where we're trying to say there's other ways that we can play around with the ventilator, but we appreciate it. If you have the tools, then we've discussed the tools and their benefits ad nauseum in the last 3 episodes, I think. So.
Yep.
All right, Troy.
Okay. Why don't you put up the next slide? All right, here's a patient that transferred from an outside hospital on day 12 of mechanical ventilation. He was not paralyzed at the outside hospital, and the patient had severe ARDS, had a very high drive. They had been ventilating him, this patient, 10 mils per kilogram with very low PEEP for days. When he got to our institution, we immediately gave him a neuromuscular blocking agent because he still looked labored. PF was less than 150, pH was 719, CO2 was 65. Low dose pressors. Family actually refused ECMO. He's kind of late in the game, but we did offer it. And like I said, we put him on a neuromuscular blocking agent. But look at the vent settings. Tidal volume of 350, rate of 35. No auto PEEP, by the way. Or it was negligible. 85% and 5 of PEEP. That's the way this. So what's your first thought? Why isn't this patient on more PEEP, right? So
yeah, did they provide any explanation as to why they didn't even try to increase the PEEP, or did they try to increase the PEEP?
They did try to increase the PEEP, and they were scared of the airway pressures, and so they went back down. So that's the story that we got.
Mm-hmm.
My initial thought,
and this was probably not a site comfortable with proning, I assume.
No,
Troy, my initial thoughts on this patient is a concern for, since the patient had been intubated for this long, concern for some irreversible restrictive lung disease, where you wouldn't even be able to recruit anything.
Yeah, if you look at the plateau here, about 28, so your driving pressures, even though your plateau's below 30, your drive pressure is pretty high. We did go ahead and bump the PEEP up to 10 just to see. If you put the advance the slide there, you'll see the plateau went from about 28. And it's not a great screenshot, but you can see there's no flow, nothing going on, but it was in the low 40s, the plateau. So it went from 28 to 41, just bumping the PEEP from 5 to 10. The drive pressure went from 23 to about 31. So likely this patient wasn't recruitable at all. And so at this point, I'm not sure that turning up the PEEP, even though the patient's on 85%, was the right answer. We did go ahead and on this.
So it's probably good they weren't comfortable with it. That's why I asked, did they try it? Like, what happened when they try it?
But I do wonder if
it was like the obese patient, you know.
No, normal BMI, but I do wonder if they would have tried it early on, if it could have been perhaps more helpful than at this point.
Yeah. At this point, you're dealing with a different beast for sure.
Right.
I mean, you can even see some of the evidence of the stress index. And so in volume assist control, when you have constant flow, you can see the pressure time curve is like convex. It's like pointing, there's that scooping upwards, which indicates that PEEP is probably over distending. Yeah.
Right. So we did, continue aggressive care. We continued the paralytic for a few days in the prone position. But after several days with no real improvement in static compliance, we did place the patient supine, discontinued the paralytic, and we allowed the patient to begin triggering a little bit. We were able to reduce the FiO2 to 60 by that time. But every time we tried to lighten the sedation, the patient became so dyspneic with such a high effort that we had to go back up on the sedation. So this patient was transitioned to comfort care, and they were, this patient was in their 50s, so probably should never have happened, but that's exactly what happened. So my point here is, I don't know how many people use the ARDS-net PEEP tables. I think they're a great starting point for some of these smaller hospitals, but after you start, then look at your lung mechanics. What's going on? What's your plateau? What's your driving pressure? When you turn the PEEP up, does that help or does it hurt? Are you making things better? Are you making things worse? Do you have any room to adjust your tidal volume down? There's lots of things to think about that don't require extra tools or technology in order to assess. So any comments about this? Go ahead.
Did you mention the etiology of this person's ARDS?
It was sepsis.
Okay.
Yeah, they had a bacteremia initially.
Yeah, so we sort of know.
Was it a lung
experience-
source? Was it a lung source or elsewhere? Sorry.
Likely a
Just wanted
lung
to clarify
source,
that.
correct.
Okay.
Go ahead, Keith.
So we sort of know from experience and data that different etiologies may respond to different interventions, right? And if it was a secondary ARDS from not from a lung source, but from, let's say, pancreatitis or something, then the alveolar edema and alveolar involvement is not quite as tenacious, and so those patients sort of oftentimes respond better to positive pressure changes in terms of improving compliance and improving gas exchange, et cetera. So when you look at this patient, clearly, at least in my mind, the primary hospital before they were transferred to you should have done things a little differently. And can you elaborate on for the folks that might be watching that don't work in or practice in large tertiary medical centers? Could you expand a little bit about how you might have handled this patient when first presented?
So usually with patients with moderate to severe ARDS, we usually prone them early. So he would have received heavy sedation with a BIS monitor to monitor the sedative, and probably a paralytic. Not always, but usually with prone position. And for the first 72 hours, 48 to 72 hours or so, we would have continued to provide lung protective strategies, which means trying to keep the plateau less than 30 and the drive pressure less than 15. We would have continued to allow lower pH, higher CO2. We would, be monitoring all the lung mechanics with different position changes. Occasionally, we might use nitric oxide if we really were up against, had our backs against the wall. But this patient's on 85%, so it wasn't used there. But we do use it occasionally as a bridge sometimes. But that's how we would have approached it.
And Troy, you mentioned they were on 10 mLs per kg at the outside facility.
Well, the patient was allowed. They tried. The rate was not probably high enough. It sounded like he was triggering every one of his breaths with nasal flaring and signs of increased effort. The transport team said when they picked him up, he had like excessive effort, paradoxical respirations, looked panicked. So I'm sure they might have been trying. I don't know the exact vet settings that they had him on, but it sounded like tidal volumes were reaching up into the 800-900 range. So I don't know if that was from breath stacking or being on a pressure mode and just effort was adding to that. or not, because we didn't get all the details. We just got what the transport team told us.
I think this is the problem that we sometimes face, is that, you know, the reaction when someone starts experiencing hypoxemia, the first physiological response is to increase tidal volume, and then it's to increase rate. When they basically start to tire out, the rate starts to go up and the tidal volume may drop a bit. But that increase in volume is, you know, we have to understand that this potentially can worsen lung injury, particularly when we start giving them positive pressure. So when we provide positive pressure, or we're providing these volumes, then all of a sudden we've got issues with transpulmonary pressure, and they have these huge, you know, swings in pleural pressures, and likely could have just spiraled this patient's lung condition out of control, rather than taking over immediately when you see evidence of such a high drive in a hypoxemic patient. Like, they're not breathing to protect their lungs, they're breathing to survive. And that's the problem, is that them breathing to survive on a positive pressure ventilator is a recipe for disaster in terms of furthering lung injury.
Danielle, we've prone for a minimum of 16 hours. There's been some papers come out since the Prosiva trial that some places are proning for longer. We've done 24 hours before, but a minimum of 16.
Yeah, I think the ARDS guidelines are greater than 12, but the best study we have to date is the Prosiva study. So really, if you want to get the best results of proning, if you just follow their protocol, then then you know you're doing a good thing. And their protocol was 16 hours. I think when they published, the average time was 17 hours, meaning some patients just by coincidence ended up being prone slightly longer due to obviously organizing the team to unprone them, et cetera. But
all right. I don't know if we have time to talk about the stress index. We only have a few minutes left, so we might not. But if we don't, and we don't want to go to the next slides, I encourage everybody to at least look into the stress index. To me, it's you don't need necessarily any special tools. You can visualize the pressure scaler and look at the linearity of the pressure scaler, but it has to be in volume assist control with a square flow pattern. I bring this up because it doesn't really require any special tools, like I said, and it's something that you can maybe get you in the ballpark of where peak should be. If you look in the middle there, that's the pressure scaler. If you're just looking at the pressure scaler, see how it's nice and linear. That may indicate that you have, you're about the best peak that you might be able to be at. On the right there, if you look at the C, you can see how that scoop or that rise slowly increases. So you may be over distended. And in the left there on A, how it kind of the slope goes downward. This patient on the left may benefit from higher peak. So you can do this visually. There are some ventilators that actually give you a number. The magic number is 1. Over 1, you may be using too much PEEP. Under 1, you may benefit from more PEEP. But again, you don't need the special ventilator to tell you the number. You can visualize it or just hold a piece of paper up.
Yeah, there's a nice paper in respiratory care where they just hold a ruler up to the screen to see if it's a straight line, essentially, and it correlated very well with an actual stress index value. Yeah. But just highlight the top part of your slide here, Troy. This can only be done in constant flow, volume assist control, ventilation. You have to assume the patient is not triggering at all, because any effort would cause a scooping in the pressure time curve if they're breathing actively. So it's important for that. The other thing is, I did note in ventilators, so for example, the Servo U will show you a stress index if the software is installed. We used to set flows when I worked in Toronto. Our peak inspiratory flow using volume assist control, we would set it to 60 in adults, so that when they woke up, before we could switch them to a pressure targeted mode, if they're spontaneously breathing, it prevented some of the air hunger you might see if you were to set flow of like 30. But the stress index didn't spit out a value when we use flows that high. So it's important that if you want to get a stress index reading, you should turn your flow down. I think around 40 liters per minute of flow, it worked well. I think it came down to an I time. It does require a minimum amount of time to actually analyze the tracing and give you a number. So it's important that you don't try it with too rapid of a flow. But yeah.
Yep, I agree.
Yeah, because
Keith, you want to wrap it up?
Yeah, I do. I wanted to just kind of reiterate that if you have a patient that's spontaneously breathing, that a stress index that indicates under peeped might look like flow hunger, right? Or flow hunger may look like inappropriate stress index. Yeah, so that's really great stuff. I think we wrapped it up pretty nicely here with these case reports. As always, we appreciate the participants. We appreciate the panelists. We are not going to have a part 5. However, we are skipping December since everybody has so many commitments around the holidays. And our January panel discussion, which we will advertise soon, the flyer will come out with the dates and the times. We're going to sort of have an open mic night type thing. And so we're going to elicit questions from participants, and the panelists are going to just kind of respond to questions that the participants may have. Hi, Angie. So that's it.
And is it safe to say that we're all going to be at AARC?
We are. Yeah,
Yeah, I am. Everybody here. Yeah, everybody in the panel. Yeah.
What's that?
We're all going
what's that?
Yeah. So for those, so if anyone who's watching, there's right now there's only 6 people left because we're at the end here. But if anybody is at AARC, definitely try to look at the program. I think a few of us are speaking as well. So come and say hi.
Yeah, absolutely. All right. Well, thanks a lot. Our web address is up on the screen there, and this has been recorded and it will be available on our YouTube channel here shortly. And again, just thanks to the panelists and the participants. Appreciate all of you.
Thank you.